the topics to all the clinicians there, interesting topics. So today we have with us the distinguished examiners, Dr. Raj K Mani sir, who is a Director of Clinical Services, Chairman, Pulmonology and Critical Care from Yashoda Hospitals, Kaushambi, Ghaziabad. And we have Dr. T. Mohan Maharaj sir, Director of Critical Care and Pain Management Services from Medicover Hospitals, Vizag. So today's topic of discussion is, and we have Dr. Venkat Raman Kola sir, who is the mastermind behind all regular webinars. So good evening, sir.
Good evening.
So we have with two students with us, Dr. Ganga Bhavani and Dr. Manisha. Both are DrNB Critical Care Medicine residents from the Citizens Hospitals, Hyderabad. So today's topic of discussion is brain death and organ donation. So this is the area where the critical care physician plays a vital role because they are the one who will be forefront in declaring brain death and even managing the brain death organ donation and communication and dealing with the medical, ethical, and legal aspects of all these things. So to discuss, we can go ahead.
Just before we starting the session, when we actually thought about this topic, most of the students, when we appear or we take exams, we realize that many of them have no direct exposure to this kind of declarations or organ donations because of maybe not all institutions may be actively participating this way. So that's why we thought to bring this topic for our benefit of our students. And we thought no other than these two, the legendaries in the field of the critical care, R.K. Mani sir, who has been a part of the national guidelines for end-of-life care and the brain dead or organ donation. And other than Dr. Mohan sir also, who said he is the first person to initiate this kind of things in the undivided states that time. So we thank both of them for joining us and hand over to both of them.
Yes, sir. So Dr. Ganga and Dr. Manisha, you can start the case presentation. So we'll go ahead, sir. Dr. Raj K Mani sir and Mohan Maharaj.
And we have the first presentation? Yes. And we're good to go. Yeah.
She's a 62-year lady. She presented with right upper limb and lower limb weakness since 2 hours 15 minutes. That means onset time was 6 p.m. and when she arrived to ER, the time was 8:50 p.m. She also had difficulty in speech since 2 hours 15 minutes, and there was no history of seizures, headache, giddiness, or fever. Coming to the past history, she was a hypertensive on telmisartan, diabetic on metformin. Her family history is insignificant. She is non-alcoholic, non-smoker. Allergic history was nil. On arrival, her airway was patent. She was breathing spontaneously. Circulation, her heart rate was 92 beats per minute. Blood pressure was 130 by 60 mm of Hg. GRBS was 116 mg per deciliter. Neurological examination revealed she was drowsy, arousable. She was trying to follow commands on repetitive stimulus. Her GCS was E3V1M5. Pupils were bilateral 2 mm reacting to light. In the motor examination, left upper limb power was 5/5, whereas right upper limb, it was 0/5 in both upper limb and lower limbs. Immediately, MRI brain stroke protocol was done. Here is the MRI brain with DWI sequence and flare sequence. In the DWI, there was an infarct in the left capsuloganglionic region, whereas in the flare, the infarct was not established. That means the stroke was within the window period. MRI brain stroke protocol also revealed left ICA occlusion with thrombus in the left ICA and MCA. Her NIHS score was 19. So we thrombolized her with tenofovir of 15 mg at 10:15 p.m. She was taken up for mechanical thrombectomy.
What is the NIHS score?
So NIHS score, it is done to assess the severity of the score, sir. It has 11 components, total score of around 42. So if the score is more than 4 and with it less than 25, then we can, and if there are no contraindications for thrombolysis, then we can thrombolize the patient. it helps in recanalization of the vessels.
Okay, go ahead.
She was electively intubated for the procedure, and mechanical thrombectomy was done, and she was shifted to MICU with CT brain and so the immediate CT brain revealed this is a CT brain, axial cutoff CT brain, which is revealing left-sided sulcal effacement, and also there was effaced left-sided ventricle. But her force score was E2, M3, B4, and R1. There was dense right hemiplegia. But in the CT brain is revealing cerebral edema, but bedside ONST parameters were within normal limits, and we have started her on anti-edema measures. On the same day afternoon, in view of sluggish pupillary response and drop in GCS, we have repeated the CT brain, which reveal this is the CT brain, axial view of CT brain, which is again revealing left-sided sulcal effacement and effaced ventricle, and also there's a midline shift of around 4 mm. So immediately we have taken neurosurgeon consultation, and attenders were counseled regarding decompressive craniectomy, but the family did not give consent for the surgery. On day 2 in ICU, she developed decorticate rigidity. Her force score was E0, M2, B3, and R1. We have done a repeat CT brain, which revealed midline shift and left ankle herniation. This is a sagittal view of CT brain, which is revealing left ankle herniation, compressing midbrain. So family members were explained regarding the prognosis of the patient. On day 3 in the ICU, her pupils were bilateral, mid-dilated, they were not reacting. Cough reflex, Doll's eye reflex, cough, they were absent, but spontaneous breathing breaths were present. Her force score was E0, M0, B0, and R1. Next day in the ICU, even spontaneous breaths were absent. So clinical examination, including test for brainstem reflexes, were negative. Her apnea test was positive. Even second apnea test after 6 hours was positive, after which she was diagnosed as brain dead. We have counseled for organ donation, but attenders have refused organ donation.
Excuse me.
Transplant coordinator has
Excuse me, doctor.
Yes, sir.
R K Mani sir, can we ask the questions now, or you wanted to put at the end?
Now is the time to ask questions. Please go ahead.
Okay, thanks.
Dr.
So,
Mohan.
yeah, Dr. Z, whenever you said on day 3, when the patient came, GCS was different. Later on, you said ankle herniation. So then after that, the brainstem reflexes were negative and apnea test. On what basis? Because particularly, we are going to the ground level. Who are on duty at the time? Are the resident doctor or consultant? And what time was it? In the daytime or night time?
It was on the first day when she was shifted to the ICU. It was in the early morning, sir. In the immediate on the same day afternoon, because of sluggish pupillary response and drop in GCS, we have done a CT brain, which revealed that there was a cerebral edema.
You have gone through all the history. You have shown the CT scan, you have shown the MRI, you have shown the T2 images, everything has been shown. Yeah, okay.
So on the next day morning, her GCS further dropped and we did a CT brain, which revealed left ankle herniation. So on the day, during the daytime, our HOD was there and 2 other consultants along with the residents. And patient was admitted under neurophysician.
So patient is admitted under neurophysician, done by surgery, done by neurosurgeon, and the patient was managed by the critical care specialist.
Actually, they did not give consent for decompressive craniectomy, sir. So surgery was not done. Thrombolysis and thrombectomy was done, and the patient
was given, no?
Yes, sir.
So
do you think
what
that
was the time gap? What was the time gap between discovering ankle herniation and test for brain death?
It was 24 hours, sir.
That's a very crucial miss. It's too long between uncle herniation, declaration of
Actually,
brain death. We could have lost a few hours, I think, at least.
there were spontaneous deaths, sir, actually. The reflexes were lost, but the patient was having spontaneous deaths. We waited
So
until
you're monitoring the spontaneous breaths now.
Yes, sir.
So the timeline, no, these are crucial things. When did the patient actually lose spontaneous breath?
On day 4, the patient lost the spontaneous
So
deaths.
you did. How did you look for spontaneous breaths? Patient was on
So,
ventilator.
yes, sir. We have put a pressure support mode in the ventilator, sir. Before doing the brainstem, we have put initially we have put on the pressure support mode. The patient didn't have any spontaneous breaths, and then we have done test for brainstem reflexes, and then
You
again,
had a beforehand that the patient may go into brain death. The plan, the thought process was there already, no, ma'am?
yes, sir.
Yes, doctor?
Yes, sir.
She lost all the brainstem reflexes, sir, but only spontaneous breaths were there on day 3. So we were thinking that she might end up in brain death.
Good. So you are waiting for signs of brain death. That's the way. We should not lose time. Losing time to
So
identify
actually
and
what
diagnose.
you answered 24 hours is not correct. As you said, you did it immediately because the question leading has been come to you. That means you only day 4 you could able to see the spontaneous breath. So that means there was no brain death before that. No, Dr. Garu?
Yes, sir.
Yes, sir.
Good. I think I'm glad you monitored for all this and didn't miss out. Yeah.
And did you do the apnea test after consent of the patient or before the consent of patient?
We have, after the spontaneous breaths were lost, we have counseled the family members, and after the consent, we have done apnea test, sir.
So you have done the apnea test after the consent of the family that you are going to test for apnea test, or you are going to say that patient is brain dead, now you are going to do apnea test. Did you get my question correctly, or do you want me to repeat again?
Got it.
Yes, sir. Got it.
So since day 3 itself, because the patient was having bad prognosis, we were updating it on a regular basis to the attenders. And on day 4, when even the spontaneous breaths were lost, the attenders were said that there could be a possible brain death, and to confirm that we need to do apnea test. That's what was conveyed to the attenders. And after telling that, he performed the apnea test.
A practical approach, normally what problems we get is, there is when you're talking about the apnea test and the brain death, who are the communicators to the patient and patient family attenders? The problem is a doctor is going to talk about organ donation, or separate team is going to talk about organ donation to the patients? Till then only you're going to involve, or the patient, because these are all the practical experiences which I come across. That's the reason I'm trying to elucidate the issues there. So normally any hospital, any organ donation, like for example, do you have any separate team in your hospital looking for organ donation survey or something like that? How do you approach that for the patients when the patient comes to ER? Which GCS you think about organ donation? What level of GCS or what level of normally you plan?
They should not be eye-opening, sir. They should be
not the clinicals, just only asking about GCS. Normally, what GCS level you think about organ donation planning, or brain death declaration planning, or the team awareness, or preparation of the team, or making the protocols or awareness of the organ transplant coordinator involvement? When do you plan actually? Anyway, normally, yeah, it's okay not to waste much time because we have only 1 hour time. And if I am wrong, I request Dr. R K Mani to correct me, or anybody, whether Venkat, Raman or Kaladhar. Normally what happens is, when we have the GCS of 5, that time we plan to think about organ donation, brain death declaration, and inform the team of organ transplant coordinator to be prepared, because as I told you, which time was the time, we don't know. It can be 12 a.m., it can be 12 p.m. So that's the reason we have a preparedness for entire team. So when the GCS is fall, normally we all know as a critical care, neurocritical care person, whenever the GCS falls below 2, we are aware and immediately we get alert, whether you go for investigation or further repeat CT scan or look at the reason why the GCS fallen than more than 2 from the previous GCS. The same way here, anytime when the GCS is 5 and we are that time, we should be prepared for entire team. So there is a potential organ donor. So there is a potential which can be, it may miss at any point of time till the organ is being retrieved. The time gap, like, any brain death, like for example, in a CPR, your time is between 3 minutes to 20 minutes for doing a CPR, right? Because you are supposed to do CPR to brain. So like here, the GCS of 5 is alarming alert, saying that, okay, there is a time which he may come out also. You improve the patient may come out. But when the GCS is 5 or below, just think about the potential organ preparation and protection of the organs is important point. Okay, thank you. Anything else, R K Mani sir?
You see, you're quite right. Your determination of brain death and the initiation of conversation on for organ donation, they should be by separate teams. Okay, so that's why the preparation is required. You alert the organ procuring organization and the representative there in your hospital, so that the coordinator can, as soon as your apnea test is confirmed, then this conversation should be initiated by the coordinator. Once the family shows interest, then the critical care and other teams can chip in for further explanations and taking the conversation forward. Now, see, taking consent for apnea test is, there is a small change now. You can take assent. If they don't want to sign on anything, then it's okay. You can take assent. It is not
mandatory.
It's not a good practice to just go ahead, do the apnea test without informing the family or taking assent. This should be remembered.
Before that, I'm sorry to interrupt you, sir. Before that, you yourself, like for example, the primary consultant and the other consultant, we all should be aware before we talk about organ word itself. Because in the particularly, most of the organ transplantation, organ donation happens, whatever said and done, it's in the private hospitals and corporate hospitals. Very rarely, less likely happening in the government setups. Even though in Andhra Pradesh and Telangana and Tamil Nadu, it's happening now, but it's rarely. So there, the ownership of the patient, confidence communication does not come. Unless, like for example, you do the apnea test and after declaration of brain death by any one of you, somebody else and involved there as a PRE, medical social worker, or the person of organ transplant should be chipped in when before doing the apnea test, so that they get into the confidence, they understand the decision makers of the family, because that's where important comes. Because the societal relationship, societal understanding, even though wife is supposed to be owner of the body, but the decision is going to be made by brother-in-law or father-in-law or somebody who's a family head. Everybody follows his decision, or the bill payment who's going to be there. These are the certain very miscellaneous meniscus issues which can make the life miserable in later, because I myself are undergoing so many cases, I know it. That's the reason we'll come across later what to be done and all. But presently at this stage, the two things I just want to understand is that apnea test, as you said rightly, after the consent. The second thing is that apnea test doing, and at the time of GCS of 5 itself, all should be involved. Everybody, stakeholders of this should be involved, understood, come into the same platform. Thank you.
Are there any questions from the audience at this stage? Any clarification?
Sir,
anybody with confusion?
R K Mani sir, these two students will present. We both need to ask the questions. Either they have to answer or we both will answer.
They did not put any questions, sir. I am posting them to.
We are seeing the chat box.
If there is anything, I will let you know, sir. Yeah.
Somebody has raised a hand.
Yeah. Yeah, let's go ahead, sir. Let's go ahead with the presentation, sir. In view of time, we can question answers can be done by chat box. Let them case presentation start.
Yes.
Raj K Mani,
Okay,
sir.
we'll proceed then with the next case.
No, same case, sir. Same case. Let it continue.
Same case. Okay.
Continue, doctors, please.
Continue.
Actually, after the second apnea test, we have, the transplant coordinator has been counseled the attenders regarding the organ donation, sir. But attenders did not give consent for the organ donation.
So is this the last slide?
No, yes, sir. Yes, sir.
Fine. It's good. So now this is the where the problem is coming, because as I said rightly, the three types of people in the society, most of the people, one are interested but not educated. Two are the people who are educated, not interested. Third people are who cannot decide either from the ethnic issues or the cultural issues, or somebody in the sarpanch of that village doesn't want to give, because they will not allow them to do cemetery in their village if the organs are given. So such silly things we can come across. So here now you said the second apnea test you're talking about, when they were not ready to give organ transplant, and why did you do the apnea test? You said you have taken the consent, you have talked to them. So when the organ transplant was not planned at all, what was the reason for doing a brain death test or apnea test?
When the brain stem is not functioning, there is no point in continuing the life. So brain stem death is considered as death. So in order to confirm the death, we have done the apnea.
To avoid the futility of
Okay. So it's excellent word used by doctor. Nice futility of this one, whether it's equipment or manpower or the resources, whatever you call it as. If that is the case, when they were not ready for the surgery, right?
Yes, sir.
they were not
Yes,
ready
sir.
for the surgery.
At the time, why did you continue the treatment? Why you are not taken end of life care? Like when they were not ready, when, I mean, is it is an insurance case or a government case or a company case? I don't know, whatever it is.
It was an insurance case, sir.
Yeah.
So we had taken negative concern for surgery, but then we didn't take end of life care as such, so because we at that point of time we didn't know how the case would progress. Like we were not very sure that she would land up in brain death. That point was.
See, 1 minute. Now you are working with Palapu Gopal sir, who is a senior most person and who knows in and out of critical care. So, so what I mean to say that, sir, sorry, sir, Palapu Gopal sir, I know your seniority and your expertise, your expertism. We are 100% sure about it. But whatever they are talking, we are just only trying to elicit this one. So what I'm trying to say is, when the patient is not ready for surgery, when the decompressive craniotomy was required for that patient, when they were not ready to take it, what was the reason in continuing the treatment and continuing it without end of life care? And we know that immediately when uncle herniation has come.
So how did we counsel the patient? What did we tell the patient's family when the uncle herniation took place? What information did we convey?
Before that, I need to know which group they have come from, which ethnic, which culture, which area, what education, what is the family education, what is the children, what is the wife. All these things should be input into this. Then only we know. Because there are 2-3 coordinators. Sorry, sir, I'm just trying to explain. There are 2-3 coordinators. The conversion ratio for brain death to organ donation is 90% in some coordinators, 9% in other coordinators. It all depends on your communication, coordinator, and involvement, and putting into the perspective. The same organ brain death person would have been given organs if it is by somebody else in that area, is somebody's feeling. It's not that, it may be same thing with me also, but this is what really important here. The more crux here is that how early you involved, how much you educated, who's the coordinator, who are the people decision maker. Because as you said, if you see the what I mean to say, you saw the Yashoda what they said. No, there is a brain and around 8 organs are there, 9 organs, which can be then, which still we can do intestine, we can do skin, all these things, cornea, everything can be given. So almost 8 to 10 people who have been survived. Only our interest, our communication, our plan, and from the beginning, that would have saved another 8 to 10 patients. So I think that what are the things you have been used, what steps you have been used in that? Because in the position statement of the treatment and the what everybody is telling is how to manage the, see, the topic is brain death and organ donation. How to manage the organs, how to is a different topic. Here, the main thing is the brain death, the indications, then when to start, when to communicate, how to make it conversion. That should be the goal. Then how to do and all, we'll talk. Yeah, go ahead.
RK Mani, sir.
So I just want to clarify one confusion, There's confusion in the minds of people that unless organ donation is on the cards, we cannot declare brain death. Okay, there's no such statement in the TOA Act. Okay.
See, there's a TOTA.
Because determination of brain death in any case should precede conversation about organ donation. Because of the dead donor rule, unless somebody is really dead, that's why you're determining death. Unless somebody is dead, you cannot progress with the organ donation. And if you did, then there would be loss of public trust as well. And this is not recommended. But it is not clarified very well in the TOA Act that you have to sort of determine death, no matter whether organ donation is on the cards or not. But this sort of thing is clarified in the Kerala government order. Okay? That brain death declaration is a must. Whether or not organ is agreed upon by the family afterwards, then you proceed with support to the organ donor. Then intensive care continues for support of the organ donor. But if it is declined,
RK Mani, sir,
then
there is
intensive care is not to be continued. I think in the Tamil Nadu government is also de-linked from organ donation. So I do not know whether it's applicable to your state. I do not know but I think if some state has got this rule, you could invoke that rule because it makes common sense. Okay. It's not possible that you don't declare brain death if the patient is really brain dead and you can't declare it just because family has declined organ donation. It can't be, because brain death is a medical diagnosis. Okay, so medical diagnosis is something which is essential in medical practice. So these are, of course, they have to be further clarified in the TOA Act. We are working with the government to introduce these clauses so that they are absolutely crystal clear across the country. Okay? But I want to tell you this, in our own minds, we should have no doubt about death of the patient when there is a brainstem death. If you have any doubts, then you can't counsel properly. And then if the patient isn't dead, how are we talking about organ donation? And if the patient is really dead, the situation doesn't change because the organ donation is declined. So how can you continue intensive care on a brain dead patient? So these are very burning questions in the minds of all critical care physicians. And I know this has become contentious issue because people are not following strictly logic. They are worried about legal interpretation. I think there are many questions in the chat box on this issue. That's why I went into it. There are several questions on this. Do we need a consent for apnea testing? I have clarified you need an assent. Okay, if consent is there, well and good. But it's not that written consent is not there, you can't do it. What they mention is assent has to be there. Number two, I have clarified that whether or not organ donation, because it takes a while for some people to grasp it, process it, and give acceptance also. And as Dr. Mohan said, depends on how well you counsel. Some people are able to get a conversion rate very high because they make it crystal clear that it is death. Although the heart is beating, although the blood pressure is going, it is death. This communication is a skilled one and carries conviction. Okay, if you have conviction, then you carry. If there is really death there, you also offer
Venkat.
organ donation in a way that the family, it makes them feel good. That is, in the sense, gives them some solace. Okay, that is, it is a sort of an altruistic need of the departed, which is being fulfilled. So that sort of a pitch has to be there. So it has got to be a very sensitive conversation, not a matter-of-fact conversation.
Yes, sir. I think regarding brain death declaration, I think how do we proceed? I think Dr. Ganga Bhavani and Dr. Manisha, can you say what are the prerequisites for brain death test to proceed, and what is the procedure and clinical testing and apnea testing? Can you elaborate on those for
Yes,
the
sir.
interest of the other students?
So the first prerequisite is the irreversible cause of coma has to be established, sir. And other prerequisites are temperature has to be more than 36.5 degrees centigrade, and the patient should be metabolic parameters should be within normal limits, and the patient should not be under the effect of any muscle paralysis. And if we have given any muscle paralysis recently, we can examine with the help of TOF. There should be 4 twitches, the presence of 4 twitches, or there should be presence of deep tendon reflexes, and the patient should be off sedation. If we have initiated sedation previously, then it has to be at least 5 half-lives has to be completed, and taking the LFT and RFT into consideration, that means the kidney function and liver function test should be within normal limits. And and also if the patient should not be under the effect of intoxication, the alcohol level should be less than 80 mg per deciliter. So once the and we should also rule out the confounding factors, and we can proceed with the brainstem reflexes test. So then and also the patient, the blood pressure should be within normal limits, blood pressure of more than 100 mm of Hg, and in the brainstem reflexes. So first, there should be any response to painful stimulus, and also we will check 6 cranial nerves. That is for second cranial nerve, optic nerve, light reflex will check, pupillary reflex, and then oculocephalic, oculovestibular reflex, cough reflex, gag reflex we are going to check, and also the corneal reflex. So after the all the brainstem reflexes are absent, then we can go for apnea testing. So in the apnea test, so again the prerequisites should be met, and so first we have to pre-oxygenate the patient with 100% O2 for 10 to 15 minutes. And after pre-oxygenating, we have to take a ABC sample, and in which the PaO2 has to be more than 200, or PaCO2 should be within normal limits, that is 35 to 45 mm of Hg. And then we have to disconnect the ventilator and put a catheter through which oxygen O2 has to be insufflated at 6 to 7 liters. We have to give 100% O2, and the catheter diameter should be less than 70% of the endotracheal tube diameter. And we have to check for, we have to continue the same for 8 to 10 minutes. So within this 8 to 10 minutes, we have to look for 3 things. One is for spontaneous breaths. If any spontaneous breaths are present, we have to abort the apnea test, and we have to look for hemodynamics. The blood pressure has to be maintained, and also we have to look for the ECG for any cardiac arrhythmias. After 8 to 10 minutes, we have to take an ABG sample where we have to look for PaCO2. If the PaCO2 is more than 60 m of Hg, or it is more than raise in more than 20 m of Hg from the baseline, then we'll consider the apnea, and the patient has not attained any spontaneous breaths, then we can consider apnea test to be positive.
Yeah.
So,
what have you seen the spinal reflexes, doctor?
yes, sir. In other patients, we have seen spinal reflexes.
So what are the spinal reflexes normally you can see? Up to what level it's possible to have seen it?
So they could be Lazarus signs, sir. They could be triple F flexion response. That means flexion of the knee, elbow, and the ankle level. This will be mainly because of the hypoxia or hypercapnia, which stimulates the neurons of the which stimulates the spinal neurons, leading to spinal reflexes.
So what are the reflexes normally you have seen it, or you elicit can be considered that no, it is a spinal reflex and it is not a. So how do you really make the patient address? Because we have seen many times spinal reflexes stopping the organ donation decisions at the end of the time. We have seen it. What level you have seen it? What can be done up to what level? Is it like only hand movement or the leg movement or sitting up the patient? Till what level you can see the spinal reflexes?
What we have seen in our previous patients was there was hand movement, sir, and there was abdominal reflex also.
Abdominal reflex. What is it? See, we have seen sometimes patient is just sitting up and lying down with the spinal reflex. So it's really dangerous. And the movement of the legs, which normally people don't accept it because they say, no, they don't even believe it. So the awareness of that with the patient itself is important, because most of the times what happens, it's education of the entire team. No, what happens, no, it's because of particularly when patient attendants are not aware of these things, they don't even believe it. So those things are makes a very major decision changes. So you need to understand entire explanation in that only. When it comes to the test, then what is the time differences of the pediatrics and adults of the brain death timing of second apnea test?
In adults, it is 6 hours, sir. In pediatrics, according to 2011 guidelines, it was before the age of 30 days, the neonate period, it has to be 24 hours. Whereas from 30 days to 18 years, it is 12 hours. Sir.
Now, your state of Telangana is having a Jivandan. Have you aware of it?
Yes, sir.
So, are you aware of entire guidelines of the Jivandan? The rules and regulations, because tomorrow, if any court case or any medical legal, because this may be sometimes medical legal maximum times of the time for organ donation, only a few percentage of this comes this one. So what is the percentage of organ donation happening in the world with brain death?
It is highest in Spain, sir. It is 35 per million. And in India, it is 0.65 per million, sir.
Okay. What is the position statement says? Our position, IDCCM position statement, how much it says? Anyway, that's a small thing. It's a 0.8 they are told. It's okay. The issue is that it is not that in that, have you seen anything post cardiac arrest organ donation? Not post brain death. I'm talking about post cardiac arrest organ donation. Have you known? Is it done
No.
anywhere else? Many countries.
It is not done in India, sir. It is done donation after circulatory death. It is not done in India, sir.
Okay. So it is not done in India, but what is the difference? Like you have the post-circulatory arrest organ transplantation. Which organs? Already question is there. They have actually put it into the chat box. I'm sure you might have gone through. So you have any different type for different organs, or do you have a particularly every organ? Because when do you declare a brain death? Like for example, death certificate we give. So at the time, when are you going to declare or put it in the death certificate that patient is dead? Is it at the time of brain death? Is it at the time of first apnea? Is it after second apnea? Is it at the time of cross clamping?
At the time of ABG of the second apnea test, sir. The time where the PCO2 rise is more than 60 or the difference is more than 20 the baseline, that is the time where we declare the patient as brain dead.
I'm not talking about a brain death. I'm talking about tomorrow you're going to give a death certificate to the patient when you are doing the procedure. So at the time of procedure, you give a death intimation form. It is not a death certificate. Death certificate is given by the government or the GVMC or whatever it is. So what you're going to give is a death intimation form. Death intimation form, you write the time of death when. Like time and minutes, everything is written, no ma'am? Dr. Garu?
Yes,
Yes,
sir.
yes.
At the time of first apnea test, sir.
Is there, it's mentioned there in Jivandan. If it was first apnea death, you are telling the brain death. Brain death, as per the definition, is equivalent to the death of the patient. So now here, there is something called Panchanama. You all know about it? What is Panchanama? Do you know, doctors? Okay. Do you know what are the 10 steps of what is written in the Jivandan, that when do you declare, when do you say that, what is the form 3, form 8? Do you know the forms? What are the forms for?
Yes, sir. Form 10
I'm not
is
asking what is what. It's okay. What I'm telling is there is different. Health is a state issue. And normally, what are the rules and regulations any government follows? Do you know THAWA rules?
Yes, sir. THAWA Act and THAWA rules.
Tissue organ transplantation of association. Yes. What are the structures there? There is a regional, there is a state.
There's a NOTO, there's a SOTO.
Yeah.
So there's one national first the THAWA Act in the 2011 amendment. It has suggested NOTO, that is National Organ Tissue and
That's NOTO, ROTO, SOTO, the state, region, and national. So those rules and regulations, what rules do they follow? They follow THAWA rules. So tomorrow, if anything comes medical legally or issue of hospital, anything, they are going to follow that rules. Because they are the rules that every lawyer, every person is going to follow. Unless that rule is changed, whatever you read in the books, whatever, that's going to be, like as I said, it's going to be position statement, it's going to be the evidence-based practice, all these things. Those rules are going to be implemented by the government and the law. Am I right, RK Mani sir?
Yes, absolutely.
So, because I want to be assured about it, because we are all studying so well about organ donation, organ transplantation, interested, enthusiastic. But most of us, unless we know the rules and regulations, that we get into trap. So those are most important, like a Bible where every one of us has to know. So you need to know the whose authority to sign, who has to be done. Do you have an internal committee in your organization? Doctors.
we don't have a committee, sir.
Do you have an organ transplantation committee of your organization separately?
Yes, we have, sir.
Are they responsible? Are they owning? They are the person who decides that acceptance of the organ donation, or external team?
The same team will decide, sir.
No, there is a team. It's an official team and local team. And who is the declaration? Who can declare? Who is authority to declare the brain death in the hospital? The first person.
In the panel, there should be 4 doctors, sir.
Everybody, the first brain death, who can be authoritative, can treat? Is it particularly neurologist or neurosurgeons or cardiologists or clinical that he can say that I'm okay, the first person who has been Can anybody or only by the subspecialist?
Only by either a neurologist who is not treating the patient, a neurologist or a neurosurgeon, or again a physician who is not treating the patient. Only these people can authorize it.
No, doctor. A person who is treating the ICU doctor is supposed to say that patient is brain dead. This is the person who is treating the patient. He is authoritative. He doesn't need to be neurologist. He doesn't need to be nephrologist. Any person who is treating the doctor in the ICU, as per Jivandan, is eligible to say that result. Finally, the Form 3 and Form 8 says there are a team of 4 people, 1 doctor from the administration, 1 from the neuro side, and 1 from the treating doctor, and the 4 people are there who are supposed to be all 4 together as to give the consent sign. Now, which comes the next point is that whenever you are doing that, once you do, as you said, you take the apnea test and you look at it. We will go scientifically step by step Vander about the discussion, because it's a case discussion. Even though your slides are very less, let us discuss all the points, whatever is possible with the given time. So already 7:50. So I don't know how much time they give allot us, but as R K Mani sir is there, let us take
No limit, sir.
discussing.
No time limit, sir. You can go ahead. Discuss extensively if you want.
Yeah. Thank you. So the issue comes here is that whenever the patient has been thought about brain death and patient comes, so the first definition you already told about ABG, told about temperature, told about everything. So what is the definition of death? I just want a definition of death.
Permanent cessation of either both respiratory and respiration and circulation, or a permanent cessation of brainstem function is defined as death.
Is there any criteria, as she told that before we talk about brain death, we have to tell the temperature, we have to talk about ABG, we have to talk about all these things. Is the definition includes those also for death definition? Like for example, a broad dead patient comes to emergency department. So what are things you look for immediately? Because over time, rigor mortis comes, that's a different issue.
When a broad dead patient comes, there won't be any pulse. Pulse and blood pressure will not be. We could. So
pulse is not the difference in blood pressure.
Yeah,
you go for CPR. Okay, fine. The same thing for
even after CPR, the ROSC will, if it doesn't obtain, then we take the ECG and then we declare as a circuit.
ROSC is not there. We look for 5H5T. Okay, that is very important. Then the point what I'm trying to drive is that temperature matters. And in the death when it comes, we all know everyone, what is the difference, the duration time between the biological death and the clinical death? Which is there in your ACLS with the diagram. With the nice color code. How much time? How many minutes? 3 to 20 minutes. Okay, coming to that now, you have done it. You said after ROS does not come, you go for this one. Now, as this talk is only about organ donation, organ brain death and all, as you said rightly, who is the person who can give consent for organ donation? Who is eligible to, like as for example, I asked you the question, who is eligible to declare the death or brain death, who can decide. So same way, who is eligible to give the consent for organ donation?
Next to kin, sir, that is spouse or children if they are more than 18 years, or parents, sir.
So is it all or one person?
One person, sir.
So as
the
medical
new
legally
rules
one
also
person.
include, the new rules include siblings also, and grandparents or grandchildren also. But of course, they mentioned it in a certain order, which you can use as a hierarchy, although explicitly they have not mentioned a hierarchy, neither in Indian law nor in the TOA Act.
So this is where entire problem is coming. As R K Mani sir said, different state has given the family bar spouse, and the TAWA has given spouse bar the family. Because I am the victim of that, we know it what is happening.
Absolutely, and they've given a certain sequence, and better to go
As a
by that
priority
sequence.
person.
Yeah, better to go by that sequence, although it's not explicitly clear. What is the hierarchy? There's no hierarchy.
The second important point here I would like to drive is when somebody is not there,
in
you
Indian
should
law,
prove it that.
This I've confirmed with lawyers as well. So that is the issue. And one more thing I must tell you, the Birth and Death Registration Act, okay, 1969 Birth and Death Registration Act, which says loss of all evidence of life. Okay, permanent loss of all evidence of life. Birth, any time after birth. Okay, that's as vague as it can get. And then you have another definition in TOA, which says death in a cardiorespiratory sense or loss of all activity of the brainstem. It doesn't say loss of all activity of the brain, whole brain. It says of the brainstem. Loss of all activity of the brain is the definition in the US law. But in the British law, it is brainstem. We have taken the British law. Okay. So these are the nuanced understanding. There is something called a unified definition of death, UDD, which exists in the US. For India, we are trying to arrive at this. Even at this time, we are engaged with talking to NATO and the Ministry of Health in merging these two definitions together, having one definition. Right. So when you see somebody brought dead in the emergency, you are utilizing the Registration of Birth and Death Act. Okay, there you're using that. You're not using TOA for that. So when there's no sign of activity and you see there's no sign of circulation, no breathing, then you declare as death. That is unusual cardiac death. You understand? Cardiac death is easy enough. Everybody understands, relates to it. Nobody will question you. But brain death needs specific determination. That's what is defined in the TOA. Is there any clarity now? I hope there is clarity. If there isn't, please ask me. Yeah. When we are finished, if you have any questions about donation after cardiac death, I am willing to answer because that is also work in progress. We don't have it in India, but we will have it soon.
Another question to the students is, as Dr. R K Mani sir asked, how many hours you are taken after brain death? Can you see without seeing the looking at the patient condition, how much time? So what is the sequelae of post brain death? What all things happens and what time? Can you tell doctors? Because maybe you all know it, but let us be knowing for all other people also who are viewing it. It's very important. Can you hear me, doctors?
Yes, sir. So the brain death ischemia, it progresses from rostral to caudal, sir. So initially, whenever there's a cerebral ischemia, there'll be decrease in blood pressure, there'll be decrease in heart rate, and there'll be decrease in cardiac output. So as the ischemia descends, when the pons is involved, so there'll be Cushing's reflex, decrease in heart rate, increase in blood pressure. So when the ischemia descends to the medulla oblongata, there'll be autonomic storm leading to rise in heart rate, tachycardia, and hypertension. As the ischemia progresses to spinal cord, so there'll be decrease in heart rate, decrease in blood pressure, and cardiac output because of vasodilatation.
So what are the complications? So like, for example, after brain death, you have been given and your consent has been given by the people. So what is you have an entire team in your hospitals or somebody else, the coordination has to come and people has to come. So in that, in the sequence, what is the thing you're supposed to be done? What are the steps to be done? Because when are you going to inform the Jivandan? When are you going to upload your documents and how you are going to take care? How you going to manage as intensivist the organ donor OD?
So whenever there is autonomic storm, it can leads to raised blood pressure, leads to raised cardiac afterload, which further can cause myocardial ischemia, arrhythmias, and also it can have an impact on the lung, causing neurogenic pulmonary edema. So in such cases, and then when the ischemia descends to the spinal cord level, there could be hypotension because of vasodilatation, sir. So we have to optimize the patient with fluid, and if necessary, we have to initiate the vasopressors as well. And try to optimize the blood pressure and try to maintain the organ perfusion.
So there is vasoplegia. You must use the word vasoplegia. Okay, that explains why you have to give vasopressors and also vasopressin. That's also becomes deficient.
So
there are some neuroendocrinal deficiencies. Which are they?
There are two main things which can happen, sir. One is hormonal deficiency, and also there could be inflammation. And if there's any loss of postpituitary function, the patient can have polyuria leading to diabetes insipidus. And if there's any anterior pituitary deficiency leading to thyroid hormone deficiency and ACTH deficiency, then we have to supplement thyroid hormone as well as methylprednisolone. And for inflammation also, even inflammation can decrease the graft survival, and also it can decrease the procurement of organs. So we have to replace the hormones.
So what does endocrinal replacement mean for support of the organ donor?
If the patient is it can be if the posterior pituitary is involved, then the patient can manifest as a polyuria. That means urine output more than 4 ml per kg. That is more than 200 ml in more than 2 hours. Then we have to suspect diabetes insipidus, and then we can replace with vasopressin, sir.
Can you have brain death without DI?
Yes, sir, we can have.
Yes, we can get brain death without DI. That's a very important point. So if you have refractory hypotension, how do you treat it in support of the organ donor?
So first we have to try to identify the cause, sir. If there's any ongoing blood loss, then we have to think of replacing with blood. And it can be because of vasoplegia, and it can be because of hormonal deficiency, or it can be because of decreased cardiac output, or it can be because of ongoing fluid losses because of diabetes insipidus. So first we have to try to optimize with the fluids. And if the blood pressure is, then we have to go for vasopressors.
Yes, you should give then. That's an indication for steroids, high-dose steroids.
Methylprednisolone of 15
methylprednisolone and vasopressin.
Vasopressin.
Because that can go deficient in making it refractory. So these are the indications for neuroendocrine support, hormonal support, so-called hormonal support.
A lot of controversies on this are there. And just before that, what happens is, as we are talking about brain death and organ donation, when exactly, like for example, till that time, you are bothered about brain and you want to manage the brain. You want to manage the cerebral perfusion pressure. You want to take care of the brain to protect the brain. That is the main goal of our treatment when patient comes to neurocritical care. But when exactly you're going to turn totally and say that, no, I'm going to take care of other organs. I'm not bothered about brain, because this is the time you're going to totally turn over. So this is where exactly comes. Till the brain death happens, you have to take care of entire organs. Till that time, you are worried, but still okay. But your focus is on this one. So that is where, what are all the important points to take care of the organs, and what are the minimum things? For example, what are things stepwise manner immediately once you decide about the brain death is happened, and likely think about that your patient accepted, your attendants are agreed. but patient is NACO positive or HbA positive, will you still go ahead and do all the things or no?
If the patient is HbA positive, then another patient with HbA positive can still receive the kidneys. So if we have any such recipient, we should continue protecting other organs.
Good. So which are all the cases you cannot think about organ transplant? Which organ donor patients you don't?
A patient with severe sepsis.
Okay.
And
most of ours is bread and butter is sepsis. Our ICUs.
Patients with T-cell leukemia and measles virus, parvovirus.
Good.
A patient
you read the position statement well.
Who is having active malignancy. Then.
What was the age of your patient?
62.
How much?
62.
62. So which organs cannot be given? Age limit is there? Same, just after what you read, next to it, it is there in the chart. As per the position statement, normally, here ourselves, as per the noto soto, there is no actually limit. It depends on the patient. Even 75 years old man, if the kidney is fine, they will actually transplant because recipients don't accept. The problem comes here is that you are doing your organ transplantation in your organization. Your organ donor is there in your organization. The recipient has to come to your organization, your hospital. So how difficult it is. So normally every person, whoever is giving organ donor, you are not supposed to communicate anybody whom the organ is going. Is it really possible in your center to do that? That it is not knowing who is given to whom? Because patient attendants are there, donor attendants are there, recipient is there, recipient attendant is there. As per the law, you are supposed to keep it secret. How difficult it is? It's a practical issue, am I right? It's a controversy. You are not supposed to disclose officially to anybody. Am I right? You know that?
Sir. Yes, sir.
What R K Mani said?
Absolutely, yes.
But here, as per the organ donor, we are doing in the same next theater. The recipient is there and the donor is there. Next to this attendants, those attendants are sitting next to them. How is it possible not knowing them, whom they have been given? As per the law. So even if you see as per this, the kidneys only up to 60 years, liver up to 60 years, kidneys with pancreas up to 18 to 45 years, and only pancreas below 50 years, and heart 45 years, lung 60 to 65 years is been given. So which is a grade of recommendation of 2B. So with that, but we don't normally, as long as we look at every invasion, what are the invasions? How do you protect each organ? Because you have certain rules. You want to be sodium this much, you want to be, see, you don't want more water for the lung, you want more water for the kidney, you want less. So how really you would like to manage? Because the team has to come. So what are the tests you do? What are the tests you send for the organ donor?
So we have to send basic tests like complete blood picture, renal function test, liver function test, blood grouping, viral serology. Along with that, we have to send blood cultures, endotracheal cultures, urine cultures. And we have to continuously monitor the patient, sir. Keeping a target of blood pressure of at least of 100 mm, systolic blood pressure at least of 100 mm of Hg, and urine output of more than 100 ml per hour. GRBS to be more than 100 mg per deciliter. Hemoglobin more than 10 gram per deciliter.
See, for each organ, what are we have to do? 2D echo, we have to do TE, we have to do bronchoscopy. Sometimes we may have to do biopsy of the liver after opening it, because to make it how it is, other than other things, and you have to send all the cultures of the patients, blood cultures, urine cultures, pan cultures for the patients of donor, because when the patient is in ICU, before the patient is being taken into this one, later on it may grow because there's a latent period, even including like, like malaria has been started that day only. It only escalate and come back to the only donor and recipient, not to the donor. So all the things, and if you remember last few years back, everybody has to be tested COVID. So without COVID test, we are not supposed to declare also about organ donation. So even though, as you said already clearly, measles and viral, all these things are there. So how it has been done? Immediately you get all the, each organ separately. You have to get a cold storm, you can get a stress response, all these things are there. At the same time, managing that and following it up. So particularly what happens, you already told regarding the diabetic insipidus. And at the time, because of the hypothermia, you need to keep the patient warm, temperature. What all things should be maintained? What level should be maintained?
So temperature should be at least more than 36.5 degrees Fahrenheit. So blood pressure, systolic blood pressure of more than 100 mm of Hg, MAP more than 70 mm of Hg, and sodium less than 155 millimoles. If we are thinking for a cardiac donation, then we have to do a 2D echo. And if the ejection fraction is less than 45%, then we can even go for pulmonary artery catheterization. And for the lung transplant, we have to go for a lung protective ventilation, and with a P-plats to be less than 30 centimeters of water, PEEP around 6 to 8 mm of Hg, and FiO2 with the minimum FiO2 possible.
For example, there is, we all know that organ donors are less, recipients are more. But whatever the case it may be, we are in the like periphery, you are in the major city like Hyderabad, we are very small city like Vizag, but not far away. So we need the entire teams to come there and all. How long you can maintain the organ donor, organ management, protection, protective organ donors, how long you can maintain?
As long as until the blood pressure and hemodynamic, the organ perfusion is maintained without hemodynamic instability, then
like for example, you are trying to maintain, so maybe as long as possible you told, maybe whatever 2 days, 3 days, depends on the age and reserve capacity of the patient, organ donor. All these things matters, agree, because particularly only RTS can be long time, other things cannot be long. And in that, what is the time you cannot wait and you need to go? As sir was asking, can you get it without DI any patient? What is the percentage of DI get in the patients of brain death?
around 80%.
Excellent. So you have everything there. Good. So in that, it can go up to, because we have managed a maximum, particularly in my center, only up to 4 days we could do. Because we need to get a heart transplant team, we need to get, because we don't want to waste any organ. We want to give the maximum, which is really, very, really tough job. We have to be on the toes because continuously monitoring everything, because everything, anything can happen. We all know. We don't want to lose at the same time. So you have to take a time when it's going to be drifting, particularly you are going to increase the inotrope so much, and continuously again redoing the bronchoscopy, more than that echo, because that's where you actually get the hemodynamics better. So that's what we are going to do. So immediately you go for, like, do you continue the feeding after brain death?
Yes, sir.
Yes.
Feeding has to be continued, sir.
Excellent. So the issue comes because brain in death patient, so you are feeding the death patient, right?
Is mainly to maintain the GRBS, sir.
GRBS can be maintained anyway with fluids also, no?
Now, this is called somatic support, and somatic support carries on for the sake of preserving organ. And sometimes one may take a decision to carry on with the pregnancy. Okay. So though the patient is dead, the child may be alive and the fetus may be alive, and one may decide to complete the pregnancy. So that is one extreme example of continuing ongoing somatic support.
Have you heard about rule of 100?
Yes, sir.
Okay. Fine. What form is very important in this, the declaration, which form normally I give it?
For declaration, it's Form 10, sir. And for organ donation, it's Form 8.
Form 3,
Yes.
Form 8, Form 10 are important. So there is a sequelae which should not miss at all, because in the beginning times it was very easy, and later on we have come, the rules and regulations have become. There is first, after brain death declaration, we need to inform the Jivandan. The later we need to inform the entire police department of that area. So they need to come. Then we have to inform the forensic department, because you see post-mortem and will be done only after Panchanama. Panchanama has to be done by the police people. Then only, because these are all the things, when in a coordination, everything comes on the time. We all know about SNDT, right? As AMPH hospitals, signature, name, date, and time. Those are crucial things in the case sheet as well as matching in the forms. Because whatever is written in the case sheet, it has to be matched with the form timings at all. And whatever is uploaded in the computers later on, even upload can be done later, but all these things matters, because after that, the allotment of the organs is done by the Jivandan government authority as per the list, as per the criteria. So in how difficult it is, what is the selection criteria of the patients? Like, for example, I want to do a kidney transplant. So is the relative, not relative, because outside, what are things, are you going to do the HLA matching? What are the tests you do to say the match of the organs? Which group? This group to other group can be given? How do you do? Which organ, what test you do? How do you match the organs? Like, for example, this patient half liver is sufficient, or you need to give a full liver, or 2 lungs, or can be given 2 lungs to the 2 people, or 2 kidneys. Is the size and the group, what all things should be matched with the donor, because donor is a group. First thing what we understand is a donor, right? So once a donor is there, what we look for is a blood grouping. First we ask for blood grouping. Then they will send the investigations for all the recipients, whether the matching or not. What are the things they look for?
HLA tissue typing.
Can HLA matching is done only with the family, it can be done, no? With the other people, it cannot be done, no? Because it is not where they send it, but how much percentage the matching they accept, because we go wait for the result of the HLA matching. Have you seen the reports of that anytime?
No,
For
sir.
HLA matching test?
No,
Because
sir.
only the HLA matching which is come nearby, only for those people they can give, because waiting list will be so many people. The group particularly, main thing comes is the group, blood grouping. So just for example, out of the box here we say, so is organ transplantation rules and regulations will affect with the blood transfusion as well? Is the same rules and regulations? Is the blood transfusion is equal to the organ transplantation?
Yes, sir.
Yes. Okay.
Yes, sir.
If it is yes, the HLA matching is done with the organ transplantation. It is done, right? Why
Yes,
it is
yes.
not done with the blood transfusions? Where is the HLA comes? Where it is happening? How are you testing? Where it is actually mainly attaches with cells? Okay, so what happens is organ transplantation means there is millions of cells of WBC. WBC HLA is more dangerous. So in this, what happens is in the blood, what is the normal cells per cubic ml of HB in RBC and WBC? You know the direct and indirect test, and okay, and you know the reactions, blood reactions, transfusion reactions, adverse reactions. The adverse reactions happens as the load comes. And particularly, you know that in some foreign countries, they do immunosuppression, no? Because they have to do immunosuppression not to have a reaction, not just the rejection of the organ. These adverse reactions happens most of the times because of this antigen antibody. So when it is happening this in the blood, when they give, out of 400 to 500 ml, the WBC content is less. Whereas RBCs are more in million. But whereas WBCs are, that's the reason one blood transfusion will not cause that much of the organ rejection, because the
Nowadays,
same blood.
we also give leukodepleted blood. We also give
Yeah.
leukodepleted blood now.
Yeah.
Places.
So that is what particularly the number, particularly most of the times we give leukodepleted for only certain type of patients, not all the patients. Why still all the patients are not getting reactions? This is the reason. The number of cells available in one blood packet is less. Because 4,000 to 11,000 per what you get the normal level, whereas not RBC. That's the reason why even except the HLA matching not required for blood transfusion, but required for every other organ.
Sure.
Any other questions, sir? RK sir? But hormonal replacement is very, very important. We all should know. And you need to start as soon as when we think about organ production. So what are the arrhythmias normally you get? Because as a neuro cases, we all know the bradycardia and sympathetic, when you have a CPP is more, heart rate is less. So particularly whenever there is hypotension, but heart rate increases. Here, particularly arrhythmias can occur, particularly hypothermia, as well as sudden DI, electrolyte imbalance, many times. So you have to look for arrhythmias very particularly. Anything else, Dr. RK sir? What are the things you think about, as you said, bradycardia? How do you treat these patients? What are the drugs?
The patient, I mean, there won't be any response with atropine, sir, because the legal parasympathetic nuclei will be destroyed. So we should only the adrenaline is the choice, sir.
Or pacing.
Yes.
Good.
RK Mani sir, unmute yourself, sir. You are muted, sir.
A lot of chat box questions have been answered.
Yes, sir.
Any more questions?
What is the difference between the hormone replacement and hormonal resuscitation?
Hormonal replacement is when there is a loss, when there is a deficiency in the hormones, that is when the posterior pituitary is involved, and when there is ADH deficiency, we replace with vasopressin, sir. And when there is in the anterior pituitary, when the thyroid hormone and ACTH are deficient, then we replace with methylprednisolone and thyroxine, thyroid hormones.
What is hormonal resuscitation? Whenever there is you're planning for heart transplantation, heart donation, and the ejection fraction is less than 45, some studies and some people have suggested and saying that giving this hormone resuscitation is important. Giving the only for persistent hemodynamic instability, you should think about giving a thyroid hormone. So, but again, anterior pituitary thyroid dysfunction is there for brain death, which is a conflicting, as we already discussed. So that's what is important. Again, in patients who have a lung transplant or distinct possibility, the methylprednisolone has been shown to be benefited, right? So that is what difference between that and this. So in this, again, it has been given as per the grading, what grade, grade 2 or grade 2B. What is the maintenance of hemoglobin you wanted to maintain for these patients?
For state 10, sir. More than 10 gram per deciliter.
So in critical care, what is the target?
It is 7, sir.
Okay. So what are the types of patients you would like to do maintenance of hemoglobin 10? What are the cases you would like, other than the brain death?
Unstable patients, it is to be target is more than 10, sir. For stable patients, even if it's 7 is also okay.
10 per MI.
Tell me again.
For unstable patients, it is 10 gram per deciliter, sir. For stable patients,
Is it a specific patient or unstable patient? How do you decide? Is it a cardiac patient or neuro patient or renal patient or the brain death patient? Which are all the patients? There is a target is there for blood transfusion. Triggering of target of blood transfusion is there, no triggers. So when?
For cardiac patients, like for patient with acute MI or something, the target should be more than 7. The target should be 10. For rest of the patient, target of 7 is fine.
Okay, please go back again. Recently, it's been study has come saying that you can maintain up to 8 for a cardiac patients, and it is as per the American, and 7 for all critical patients. And
Yes.
which are the patients of 10 or 9 depends on the what are the cases that is there in the triggers of this one in your critical care. Okay, Gopal sir will tell you. So then what else? As you said, maintain the nutrition, maintain the temperature, maintain the 100, everything has been done, right? So what are the drugs you should avoid?
nephrotoxic drugs. Nephrotoxic and hepatotoxic drugs are to be avoided, sir.
They mentioned, no? Drugs, what are the drugs? Renal and nephrotoxic drugs are supposed to be avoided. The N list, very, almost 40 drugs are there which are supposed to avoid all these things, particularly for the brain death patients, so that you can maintain all the organs, including routine, whatever you have, the drugs of phenytoin and halothane, which we are not using nowadays. Okay, particularly anti-cancer drugs of judoviridine and including rifampicin, INH, anti-tuberculosis drugs. Okay, that's the first priority which you are supposed to be avoided, because when you think about that, okay, including the routine rheumatology drugs like methotrexate and penicillamines and acetaminophen. So all these drugs should be avoided because which will reduce the donation of organs. Next, anything else? Routinely, as intensivists, we all plan for antibiotics, right? So he must be already on antibiotics. What are the antibiotics she was taking and you are giving to her?
She was on ceftriaxone and sulbactam, sir.
What is the reason for giving that antibiotic as per the antibiotic stewardship policy of your hospital? Because it's a IC bleed, not infected case, and you're telling ceftriaxone and other things on. What is the reason for giving that antibiotics to that patient the day 3 and when you are not treating the patient, only a patient on ventilator? Patient is not going for organ donation, patient is not having infection, patient is only the, as you said, everything. What are the reason for these 2 antibiotics going for that patient, doctor?
Yeah. Very pertinent questions we have to ask ourselves every day by the bedside. What are we trying to achieve with the antibiotic?
Particularly for this patient. Do you have any, what was the thought process of starting this antibiotic, doctor? No, I'm just trying to ask you, that's all. Please, never mind.
Actually, she was having
in your history, you never said infection, you never said temperature, you never said any abnormal WBC count, and you never said urine
antibiotics prevent infection? Do they prevent infection?
Is
Not
it not
known,
prophylactic? Is it
except in a very
prophylactic? Is
few.
it therapeutic?
So they know they can't, they are not useful prophylactically. So you're directing an antibiotic at an infection only, huh? It is not anything else.
The point what I would like to make here is that donor should be infection free, 100% agreed. But at the same time, no use of routine prophylactic antibiotics. I'm sure I'm not pointing out what it is, but I'm telling you that most of the times, if you see that even in the group, it has come that the longevity of price, whatever you call it as, the de-escalation of antibiotic stewardship, that most of the time, just like a most of your, even if I go to the rounds of ICU, I sometimes still feel around 8 to 10 ml of tidal volume. Suddenly we see what's happening. Is it our ICU or not? So that's how everybody feels. We need to continuously, like Janaganamana, all the 10 points has to be seen for every time, every day, for every patient. Then only the things will come up. So like that here, every time there should be some person, like for example, I tell you there are 5 students or 6 students. One person should be focused only on antibiotics, what's happening, what's stewardship. One person should ventilate even fully. One person should cultures. Like that, everybody has to go through then till only, because otherwise these things keep happening. It is not happening in your ICU. It happens in my ICU. It happens in RK Mani ICU. It happens in every hospital, every place. It's a common.
There is a question in the chat box.
Yeah.
Dr. Mohan, there is a question in the chat box.
Yeah.
Saying who will pay for all the tests and the treatment given after the first apnea test?
Very good.
When the family has not agreed for donation. Now,
No.
then comes a pertinent question: why are you doing the tests and
why you don't require to do the test when the patient admits and not
so
agreed?
the issue is, with every intervention that's not justified, you are adding to the financial burden, and which you can't redeem. So that is the issue. So it has to be thoughtful. Every prescription and test has to be thoughtful. It can't be reflexive.
I tell you with only one small 2 decades of experience, what we used to do before, what is eligible, what is not legally wrong. Point number 1, you are not supposed to bill the patient once the brain death is declared, number 1. Number 2, you cannot put that bill to somebody else officially, ask them to pay. That's another problem, number 2. Number 3, you cannot collect money from recipient, because financial things should not be linked at all for organ donation. Organ donation is the cause. This is a real crux and difficult to manage the patients. That's why what we used to do was that, so we used to close the bill at the time of a brain death and include everything indent before only, like for a patient for central line, outer line, drugs, everything, then close it till the time of what we plan for a day, so that it is officially legally right. The second point, whatever the test is done post-op management, we used to waive off from the hospital side. Or the previously what used to happen is that the bill what has been happened to manage the organ donor management, maybe 1 lakh or 2 lakh, 3 lakhs. Once the Jeevandan is been allotted the organs to that hospital, we used to share the bill to the all other hospitals. So the other hospitals were there, which includes in the bill, used to be given up to certain time, which is again, because legally, again, we need to
allows that.
Not allowed.
SOTO has provision for this. Yes.
Yeah. So SOTO allowed this. Yeah. So this is the second point. Third point, we put it as a donor. Somebody else says donor can do anything. Donor can give money. So that is what, like for example, pool or trust or somebody is managing. Is it there is somebody who manages the body to give it to the this one? There's a association called, which actually they can do that through them, which they can be done. So legally, we are not supposed to involve or interfere regarding financial. That's one of the crux of it. You're not supposed to talk about money. You're not supposed to give any incentive. You're not supposed to bribe. I mean, those are things which should not be done at all in the Organ Transplantation Act and organ transplantation procedure throughout the procedure.
So we have thoroughly addressed all issues around organ transplantation. Is there anything you want to ask us? Any other doubts, clarifications?
I think it was an excellent discussion, sir, covering all the theoretical and especially the practical aspects covered by both of you.
Mostly we covered practical aspect.
Practical aspects, yes.
But the theoretical aspect, there's so much is there. We have to
No,
read.
that is very vast.
Because we have not
very
done
vast,
scientifically, theoretically, much
Yeah.
discussion has been not done at all.
It's like the
Today.
concept of brain
Practical
death itself
aspects,
is
yeah,
a
most of the times,
whole class.
yeah, most of the people they ask these practical aspects only, sir. The day-to-day the practical aspects and the problems they face while declaring brain death and especially managing this brain death organ. I think that's very,
And
very
for
well
the sake
covered.
of students, I would like to tell another 1 or 2 points, Kaladhar, if you permit.
Sir, yeah, it's fine, sir.
Yeah. See, there should be an internal committee consisting of 4 people where they have to think about and have a meeting and have a minutes and decide about this one. And there should be external committee, and there is a government which appoints by the government hospitals where if you are, because there are 3-4 points I would like to drive into all the people who have been attending now, at least to benefit of them for the future. If I have seen so many legal cases, which I am part of it, and I know as if anything happens, there's something called vicarious responsibility. So even you are not involved in that, surgeon will go into the jail, director of the hospital will go into the jail, and all these entire permissions will go. It has happened to the many hospitals. Some hospitals have been closed because of these rules and regulations. So you should be pakka perfect in documentation, and you have to be pakka. Particularly, I 100% request every one of you, if there is any organ transplantation plan, do all video recordings and store it. And the video recordings are eligible only in the original. In a duplicate and those things, some of it is not eligible in the court of law. Only original is eligible and accepted. Second thing, when it is going to be this one, the kith and kin, that means wife is a priority. If the wife married and the wife, she's not there, you have to take consent from the family that she's not there, and you have to call them, at least record it on phone that she's not available. Then only the second thing, another point. Third point, even if they come with the fake addresses of that, saying that we have seen many people coming as a husband and wife who are not also. So those kind of things, even they come and get operated, later on the hospital is responsible for it. That is the reason the authority proof check, like a passport. Like for example, the passport, somebody else will come and give check. If the person is saying the relative, how do you prove he's the relative? Just by making the duplicate Aadhaar card, just made it, those kind of things are dangerous. You need to send verification for the RMO, MRO, those kind of things. Those are going to be saving you in future. That's another point I would like to. These are all the requests, and this is responsible. Without knowing, you are sitting in the operation theater, you will be giving anesthesia, and another person is doing the surgery, and patient is happy, recipient is happy. At the later, when the both of them get dispute, and you are in the jail. That is the reason it is called vicarious responsibility. The ownership lies with you. Even though there's something called external committee, which is being formed by the government of authority of government medical college. If most of the people, when they come, they say he is my worker and he is ready to willing to give my organ, looking at I am the boss after 25 years. Even if they go and give consent and you do the surgery, the responsibility lies with the team and the hospital. So this is the rule position. I'm just trying to explain you the rule position of the legality. So how important it is, and without, see how it manages, okay, but rule position is very, very serious. At the same time, do not keep this in mind and stop doing organ transplant. This is one of the best noble cause where you can save a lot of patients and a lot of, if it is genuine, everything is perfect. But the documentation should be perfect. That's what is very, very important point I want to drive in. And there's a committees are important. Go through the thorough rules of all the statements and everything. Whatever the recent of scientific and the methodology is different. But the state is in a health issue and you need to follow the 1994 Act to the amendments of everything. And even now, the amendment has to come into the rules, not by the position statement, not by ourselves. Even R K Mani says, will go and accept my this one, that only when it comes to the lawyer side and from their rules, it is going to be acceptable. End of life care, whatever we are fighting, whatever you are doing, it is implemented once they accept it. Am I right, sir?
R K Mani, sir.
Yes.
Your final comment,
So,
any final comments from you, sir?
I think I've had
Thank
a long
you.
session. We can now stop.
Thank you. Thank you, sir.
And
Thank you,
thank
sir.
you very much
Thank you
for
very much,
all
sir.
your
Mohan Maharaj, sir,
lively
and
participation.
R K Mani, sir, for giving very good clinical insights.
Thank
I
you
can
very
say
much for
practical
giving
aspects.
this platform for us to have.
Thank you, sir. Thank you.
Thank
Dr.
you very
Ganga
much,
and
Dr.
Dr.
Ganga and
Manisha.
Dr. Manisha.
Thank you.
For
Okay,
so much
everybody,
patience
thank you.
and your knowledge. And we wish that, and I'm
Venkat,
sure
Raman.
you have gone through a lot of
Thank
literature
you, Dr.
Yes.
Mohan.
under leadership. Thank you, R K Mani, sir.
Thank you, sir. Good night.
Thank
Yeah.
you, Kola Venkat Ramana.
Yes, sir.
Thank you all.